We're on live.
Yeah, good evening,
Give me a
everybody.
second.
Thanks, Rafi, for
Sir,
hosting me
it's
today.
1 minute, sir. 1 minute, please. Wait to, uh, wait. One minute, sir. Sir, okay. Now we are ready.
Yeah, sure. So you want me to talk? Or
So let me just give you 1 30 second to introduce you.
fine, man. So like I'm Dr. Virappan, and that's how people in Bangladesh call me, and India they call me Dr. Ilangovan Virappan. So that's the name. And I've been a nephrologist since 2009 onwards. I graduated from JIPMER and SIMS Vellore. And I was there. Many of you people would be knowing that I was between 2001 and 2003. I was in Evercare Dhaka, or earlier it was called Apollo Dhaka. At that time, I got to meet many of you, and also built lot of friends. Had a lot of friends in Bangladesh, lot of doctors, colleagues. So we miss quite a bit of Bangladesh. In fact, due to various reasons, I have to come back to India because I had my own patients all the time. Whenever they see me, they come crying. So like I was like didn't know what to do. So I then finally came back to India, and but still I think I left my heart there in Bangladesh. And my wife and my daughter also. We spent a good 2 years. We still miss Bangladesh. We love the traffic. We love the people. We love the place. So any of you people reach out to me online, offline, in India. I try to do the best possible. I know from distance, being a doctor from distance is not a easy thing for you, but still, like whatever little I can trying to do. And if God wishes, like I'll continue to be engaged. And I tried my best to build the infrastructure or nephrology per se in Bangladesh, but still the help I am not getting enough to do something much more better, so that like people don't have to struggle to come to India or go elsewhere, and then you can have good quality centers in Bangladesh itself. But I'll continue to try. That's the promise I make. So am I audible?
Yes, sir, you are audible.
Yeah. So like anything more you want to talk? I mean, you want me to talk?
Oh, sir, I just started. আসসালামু আলাইকুম, শুভেচ্ছা সকলকে। আপনারা জানেন যে আমাদের লাইভের একটা মোস্ট কজ যে আমি যে কারণে লাইভে আসি, যে অনেক ব্যস্ততার কারণে মূলত কয়েক মাস থেকে লাইভ আসা হচ্ছে না, বা আমরা স্যারকে বা অন্য কোনো ডক্টরকেও পাচ্ছি না। তো স্যারকে রিকোয়েস্ট করার একটাই কারণ, আমরা অনেক দিন থেকে চেষ্টা করছিলাম যে স্যারকে রিচ করার বিভিন্ন অনলাইন প্ল্যাটফর্মে, অফলাইন প্ল্যাটফর্মে। স্যার যখন বাংলাদেশে আসছিলেন তখন আমরা চেষ্টা করছিলাম যে স্যারকে দেখানোর জন্য, অনেকেই আসলে স্যারকে রিচ করতে পারেনি। এইসব বিভিন্ন কারণে, এবং পাশাপাশি আমাদের পার্টিকুলার কিছু কোশ্চেন আছে যেগুলো আমরা সবসময় আনসার খুঁজি। তো এইসবের কারণেই মানে স্যারকে ইনভাইট করে, এবং স্যার অলওয়েজ অ্যাকসেপ্ট আমাদের ফর ইনভাইটেশন। So that's why, sir, thank you very much for accepting our invitation and welcome to our group. As you know, we are all the transplant patients are here. We have thousands of questions, and the most important question to you: how we will get you in Bangladesh? Is it possible to get you online? For us to go to northern part of India is quite difficult, or the southern part of India is quite difficult, and not we all are available or able to go there, and we always try to get you via online or offline platform. When you come to Bangladesh, most of us are trying to get you, but we are not well informed how we will get you or how we will get you in Bangladesh. The question from all to you is how we will get you in online platform.
So in online, no, there are the two ways like people can reach out to me, and so one is they can connect with me um, through like, so this is a website. I'm just sending the link. So if I send a link, you will you'll be able to
You
access it
can send it in a comment box.
in the comment.
Yes, sir. And later I will post it in the group. You can say it.
Yeah, so I'm just put it here in the private chat place. So this is one link, and I'm sharing with you another link. So one link people don't have to pay. Another link they have to pay to get an appointment. So there are two links because sometimes the payment can be an issue. So I didn't want that to stop people. So the first one is we have to pay. Second one you don't have to pay. You just have to book it. So we will call you back. So this how these are the two ways. And the third one also you can do, that is you can reach out from the hospital website itself. That is a little bit cumbersome, but like people who can navigate can also book through the hospital website also. There's something called telemedicine. So these are three methods of reaching out. This also. So there are three methods to reach out.
Then I will share them in a post with the group, and I read all the links.
Can you repeat? I didn't get.
I get all the links in the private chat. Later, I will expose them.
Sure.
Okay, sir. So we have questions. We have previous questions. We have live questions. That's like different questions.
Yeah, sure. I'm good to take. Yeah.
Okay, sir. This question is from one of us. Assalamu alaikum, sir. And he is about 11-year post-transplant. And he didn't have any medical problem, but some of the doctor are suggesting some supplement. Is it safe for him, or is it necessary to take supplement for all the transplant patients?
So there is no need to take any supplements, because as long as you are eating healthy diet, you really don't need it. So supplements meaning like, can you just specify like is there any particular reason they are giving? Uh, so that is different story, but like otherwise generally it's not required. If there is a problem, there is a disease for which they are giving, that's different story. But otherwise, there is no role for supplements.
Supplement like someone is taking
Rafi,
vitamin
your sound
C,
is not
someone is
clear.
taking
So
specially
I cannot.
tophrite a lot.
Yeah, your sound is not very clear.
So can you hear me now?
Yeah, I think the problem is with the internet quality, I think, or maybe something you have to do. Or maybe you can switch off the video for a while. No,
Is it okay
yeah,
now?
no, you don't switch off the audio. Switch off the video. Keep the audio on, so that way it will be able to easy to communicate.
Okay.
Yeah, now you try speaking. It might be better now.
Okay. Supplement like someone taking zinc or someone taking especially tocopherol or tocotrienol, someone is taking calcitriol, someone is taking calcium, someone is taking. Many of us are taking bisphosphonate. Is it safe or is those are safe?
So, so bisphosphonates, no, bisphosphonates is indicated only when um, is indicated only when you really your bones are really weak. So there's something called you need to do you need to do bone mineral density. Okay, so bone mineral density, and if it is if the Z score, there's something called Z score. If the Z score is less than -1, only then. So there's something called T score and Z score. So you need to look at the Z score has to be less than 1. Only then some form of therapy is required. Treatment for osteoporosis is required. And bisphosphonates can actually increase creatinine in people who have a creatinine which is more than say 1.5 or something. So in those cases, the creatinine can actually increase. So that is why it is not really required actually. But the standard of care is like you can take zolindronate or you can take denosumab. Those are slightly more safer, slightly safer forms. But otherwise, bisphosphonates in normal, when the creatinine is very good, there's no issue. You can take, and that is for and so bone mineral density is what determines, and you should not look at T score. You have to look at something called Z score, because I have seen doctors looking at T score and then unnecessarily treating patients. And so the new generation agents, no, like denosumab and all, it has been shown that if you take the treatment like 1 or 2 doses and you stop taking the treatment, it can increase the fracture risk even more. So if you are taking, you can take bisphosphonates, and if your creatinine is stable, you can continue to take. If your Z score is less than -1, so that is one. And regarding calcitriol, normally we give it for the first year because when being on dialysis, the bones can become really weak, and in the first few months post transplant, the calcium goes very low, the phosphorus levels go very low. So to improve the calcium balance, we can take calcitriol. But the only you should also, what I've seen in Bangladesh more often than in India is, so if the calcium, if the serum calcium is low, um, then calcitriol can be continued for some time, for a few months or a few months or years. But you have to be careful if you take a long-term calcitriol, the calcium levels can go up. So ideally, the calcium level should be around 9. It should not be below 8.5, and it should not be above like 9.5 or 10. Okay, so it should be in the middle sweet spot. If you have too much of high calcium in the body, that also can cause problem, and if too less calcium also can cause problems. So that way, like you need to be careful. Taking the first year, it's okay, and some patients, if you have you can have very high PTH even after 2 years, and those patients generally tend to have high calcium also. So first year, yes, long term calcitriol is not good to take when, and the only indication where you can take long term calcitriol is when your creatinine is like say 2.5 and your PTH is also high. So I'll summarize what I said. So if you are in the first year calcitriol, okay, and if your creatinine is more than 2.5, it's okay. But like if your PTH is within normal limits, calcium is high, whatever may be the stage, you need to stop calcitriol. So if calcium is high and PTH is very low, then we need to stop.
Sir, am I audible to you?
Yeah, you're audible. Yeah.
Okay, sir. We have a very critical question. Some of us are having cyclosporin and they have glaucoma issues. And nephrologist wants to decrease the prednisolone, but when they decrease prednisolone, creatinine got high. And what should be the correct approach?
So it is very dangerous to stop prednisolone anytime after the first 3 to 6 months. So after 6 months, trying to change the dose, you should be very careful. So normally, don't try to reduce to levels less than 5, unless the doctors have really given you some kind of the induction therapy protocols in the beginning. So late steroid stopping, reducing can be very dangerous. So like, there is something called steroid-free transplants. Okay, I'm sure a lot of you will be aware of. So there we stop the steroid in the first few days post-transplant, and then these patients live very long without steroids. So that is steroid-free, but the treatment protocols are slightly different in steroid-free transplant. And even in patients who was having steroid-free transplant, some of them do have mild rejection, and they are started on steroids and they continued to take steroids. And even if glaucoma is there, that can be easily be managed with the eye drops, rarely with surgeries in the eye. And you should not reduce your steroid dose, especially beyond the first 6 months. It's been clearly shown that reducing or stopping steroids after 6 months is very harmful for patients. So some of the patients, when they're taking 10, or then if the doctor wants to reduce to 5, that is different story. That is okay. And then when some of them taking 7.5 reduced to 5 is also okay. But reducing 5 to 2.5 or stopping is not okay.
থ্যাংক ইউ স্যার। আপনাদের যদি কোনো কিছু বুঝতে কষ্ট হয় বা সমস্যা হয়, আমাদের জাস্ট কমেন্ট সেকশনে, মানে লাইভের কমেন্ট সেকশনে কমেন্ট করবেন, আমরা ওই সব স্পেসিফিক পোর্শন বাংলায় কনভার্ট করে দিব। তো আমি আপাতত কোশ্চেন নিচ্ছি, কোশ্চেনগুলো আপনাদের পক্ষ থেকেই করা, এবং আপনারা এই কমেন্ট বক্সে প্রশ্ন করলে আমার জন্য আরেকটু ইজি হতো। Let's take another question, sir. We have 3 or 4 questions. The question is same. They are long time post-transplant recipient, and they are doing great, but the problem is they have protein leakage. And what is the permanent solution? And another problem is when they take medicine to stop protein leak, and the creatinine got high. And after getting high creatinine, they got afraid. And what should be the solution? And is it possible to get transplant without protein leakage for the long time?
Yeah, so protein leakage has a lot of causes. So one of the cause we all will be worried about is rejection. So late onset protein leakages. So ideally, what we need to do is first is we need to verify is it really present. So you need to do more than one time urine test to confirm that there is real protein leakage, because urine test sometimes there can be mistakes. So sometimes it can be falsely positive for urine leakage. So you have to be first confirming it, because many of the patients who reach out to me, later on we find out that they do not have protein leakage when we do more accurate test. The best test to find protein leakage is urine protein creatinine ratio or urine albumin creatinine ratio. So you should not look at trace protein 1 plus protein, albumin 1 plus, and then get worried and confused. You have to do a quantified test, that is albumin creatinine ratio or protein creatinine ratio in the urine. That is point number 1. Point number 2 is we need to find out what is the cause of proteinuria. So some causes of proteinuria are very dangerous, and some causes are not so dangerous. So anybody who is having proteinuria definitely needs a kidney biopsy test, whatever may be the duration of transplant. For first week, first month, first year, 10 year, 20 year, anytime you need to. The advantage of that is if you do a biopsy test, we'll know what exactly is the causing this proteinuria. So each cause has different treatment. Some of these proteinurias can be because of long-term transplant, like 20 years transplant. Patients are having cyclosporine, tacrolimus. That itself, drug itself, can cause some damage. So the cause of proteinuria is like so many, and so anybody with proteinuria should not panic, should not get really worried. First thing is do a biopsy and figure out what is the cause. For example, if there is an IgA nephropathy, then that treatment is different. If the patient is having rejection, that treatment is different. And if it's a FSGS recurrence, the treatment is different. And sometimes people can have repeated urine infection, then also they can proteinuria. Again, the treatment is different. So first is biopsy. Like first is find out the cause. Okay, so once the cause is identified, then you have to decide how to treat. So a lot of patients they reach out to me and ask me, sir, I have I have proteinuria, I have proteinuria, they really panic. And then somebody starts some on telmisartan, losartan, and then the creatinine keeps increasing. Okay, so don't panic, but more importantly, find out the real cause of proteinuria, then try to treat it. Some of the causes of proteinuria does not really cause any long-term problem. So some people imagine they're having 0.5 proteinuria, half a gram, 500 milligram, 1 gram, 10 years later, 15 years later, they may not really cause too much harm. And you really don't have to attack it, like really worry and try to treat it aggressively. But generally, we need to find out what is the cause. So what I see is
Sir,
many
we
times
have
doctors treat with some medicine trying to stop it. It is not like a leaking tap. You are just switch off and it stops. You need to find out why it's leaking. Then you try to switch off. Then you try to treat that cause. Then it reduces or it stops. But don't try to give some generally doctors give telmisartan, some kind of these drugs, and that's not the right way to treat.
Sir, as far as I know, the 40% of patients with IgA may recur IgA nephropathy after transplant. And we have many cases like that, patient having IgA after transplant. And if they get IgA again, what should be the proper treatment? Will she get CKD again, or is it totally stoppable or no?
Generally, IgA post-transplant, even if it comes, the kidney can survive more than 15 years. That is a half-life. And in our developed countries, in Australia, United States, they say that the IgA does not cause significant loss to the kidney, damage to the kidney. But in Bangladesh and India, we don't see like that. The IgA can be very dangerous. But out of 10 patients who have IgA post-transplant, I would say like only one will have like very aggressive disease, or and who aggressive disease where proper treatment is required. Most of the cases, the IgA recurrence will be there in the form of protein leakage, mild change in creatinine, which is normally 1, may become 1.2, 1.3, and that this kidney still will continue to work for more than 10 years, 15 years. So this happens 90% of the time. Only 10% of the time it can be like it will require some aggressive treatment. So there are some treatment protocols when it's violent. So that has to be followed. But otherwise, generally what happens is you have to take correct dose. Like for example, these patients should not get um, the steroids. They should take at least 5 milligrams. They should not stop steroids. And secondly, the mycophenolate, the CellCept medications they take, that has to be appropriate dose. So you cannot give them very low dose like 250, or you can skip the dose. These two drugs have shown to be useful in reducing that kidney damage because of IgA. But other than that, only if it's violent cases, then we give protocol different treatment. The usual treatment will be a small course of steroid, or you can give IV somatostatin, or subcutaneous somatostatin in very aggressive cases. So I treat differently only in the very aggressive cases. Most of the cases are generally mild, where you really don't have to treat aggressively.
Sir, one of us is Farhan. He is from Chittagong. His mother died due to IgA nephropathy, and he is also a IgA patient. Now he is in Australia. The main problem is the doctor of Australia isn't getting enough medicine. They said many of IgA medicine are trial or Indian or Asian subcontinent. They can't use them, but they know these are well, but they will use them after a certain period or certain trial base. And is that a problem to use the developed country as not using trial-based medicine like we're using in Bangladesh or India?
No, thing is like the IgA nephropathy is not a single disease. IgA nephropathy is a very heterogeneous disease. So what we mean by heterogeneous is IgA in one patient, they don't need any treatment. They live 100 years without the kidneys getting damaged. That is one group. Another group of patients is the disease will be so aggressive that you need to give some kind of injections like cyclophosphamide, rituximab, or so these kind of different kinds of problems can happen in a very aggressive problem. So that needs aggressive treatment. And in a majority of the patient, it is a very slowly progressive disease. So what normally I treat is so many of the doctors they only give them in developed countries tell ARBs like the drugs like ARBs, and now slowly some of them are giving long enteric acting budesonide, but still people are extremely hesitant to give them medicines because the evidence guidelines are all not very. There is no clear consensus in IgA nephropathy treatment. So normally what I do is I give them very low dose steroids, give them mycophenolate, and then see how they respond. 30% of them, the IgA gets cured completely. So in these patients, after 6 months, we can even stop these medicines and give them other forms of therapy. In other majority of the patient, if there is even a partial response, then we can give only mycophenolate and not giving steroids. Just give them only these drugs. And other newer agents are getting into the market now, which are approved in developed countries and developing countries. But generally in India and Bangladesh, we don't use any unapproved drugs. Normally, I don't use unapproved drugs. The only drug I used to use before was budesonide, and that I was sure that FDA would approve, and FDA approved in 2021. And but otherwise, the each patient with IgA is different. So it is not like diabetes where all the patients who have blood sugar you take either tablet or insulin. It's not like that. IgA is not a single disease. It's different disease. Each patient responds to one group of medications that the doctor has to use his skill, knowledge, and then appropriately treat. And if you do it 9 out of 10 patients with IgA, we can get good response.
Thank you, sir. And this question is from Pallab Chakma. Hello, sir. This is Pallab Chakma. He is your regular patient. His recent problem is he has sore on his tongue and mouth, and how he will get rid of this. And another, this question is from many of us from the donor part, not the patient side. And he is patient, though he is patient, but we have this question from the donor, like the donor is his grandmother, or his father, or his mother. Most of us are suffering from many of our donors are suffering from this sort of problem, having sore on tongue and uh, beyond the teeth or in gingiva.
So, what exactly is the donor problem? They have problems in the ulcers in the tongue.
Uh, yes, sir. Tongue, gingiva.
Okay, so basically, tongue ulcers are usually because of nutritional problems. So, especially in patients who the transplant patients, because they take immunosuppressive medications, some of them develop malabsorption. Malabsorption meaning whatever food they're eating, the vitamins, minerals don't get absorbed. So, one thing what we can try in case medicines don't work is you can try injections, the multivitamin injection once a month, and generally this works. So because how it works is because these patients um, the multivitamins are not getting absorbed into the body, so usually
But is
injection.
this cyanocobalamine?
Yeah, methylcobalamin, even general multivitamins can be used. Generally it's cyanocobalamin, and a small proportion of these people they become like really really sick because cyanocobalamin does not get absorbed into the body, and if you give it as a tablet it still it doesn't work, it doesn't get absorbed. The same thing if you give us an IV injection, it works. That is cyanocobalamin. Number two is you can give riboflavin, especially with oral ulcers. Riboflavin is useful. And in recipients, sometimes what can happen is if their blood sugars are uncontrolled, if the doctor gives them multiple steroid injections, and if they got some rejection therapy, and so they can develop something called candida in the mouth. So these candida, the doctors, sometimes the candida doesn't come as white patches. It can come as painful ulcers. It can come as throat pain, stomach pain, and they're not able to eat. So how to treat it? You have to give fluconazole. But unfortunately, if you give fluconazole, In transplant patient, the medicine, the tacrolimus and cyclosporin levels go up very high. So you can use very low dose, 50 mg twice a week, or 100 mg twice a week. If you take, that will be enough to get rid of the fungus infection also, and at the same time the medicine levels does not go. So that is, so these are the three drugs you can use. One is an injection B12, riboflavin, and rarely, and you have to be very careful when you use this, fluconazole. And only under doctor's advice you have to take fluconazole. Don't take daily, and you take small doses, 50 or 100 milligram maximum, and take two times per week. So generally it is these things generally disappears. uh, so that is what. And regarding the ringworms, I've seen like some of the patients have very resistant ringworms. So so in fact, a couple of few of the patients I'm treating, Bangladesh patient I'm treating. So you have to give a combination of, again, fluconazole 100 milligram two times per week for like 3 weeks, and don't have to take it daily. And terbinafine you have to take daily for a month, and ointment, minocycline ointment, or clotrimazole ointment. And generally, if you use, the ringworms will go away. Oral ulcers also will improve.
So one question: does fluconazole increase tacrolimus level?
Yeah, very much it increases. So up till like 50 milligram, if you take, half the patients, it doesn't do much increase. 30% nothing happens. 70% it definitely increases. And so one way of that is, like, if you use daily, definitely it'll increase. So if possible, you have to use small doses, alternate days, like that. But if you're and the attack levels can increase 5 times. So like normally, if your level is 6, and if you take fluconazole 200 mg for like 10 days, it can become 20 or more than 20 also.
Okay, sir. This is from another question. She is well. She has transplanted about 4 or 5 years back. So the problem his WBC and RBC level isn't constant. It is getting increased or decreased, and he's taking the same dose medicine like mitochondria other medicine, but WBC level isn't constant, and RBC is the same.
So WBC usually will not fluctuate so much. So it's either high or it's low. So sometimes imagine it's 12,000, 13,000, 14,000. In some of the patients I've seen, like, they live 20 years with the same count. And this high count, is generally because of body abnormally reacts to low dose steroids. So that is the reason why they have high count. And if there is no symptoms and these counts are there for many months, you can ignore it. And I've rarely seen patients having WBC count even up till like 18, 19. So these people live normal life also. And regarding low counts, so again, you have to find out the cause. Most common cause, what I've noticed, especially in Bangladesh, what I've noticed is when the creatinine goes up, when the kidney function worsens, generally doctors tend to increase the dose of mycophenolate. And when they increase, the drug toxicity, the side effect of the drugs also increase. And that can cause very low WBC count, like 2000, 1500, 1000. So that can be quite dangerous. So mostly it is because of mycophenolate drug, and especially in the first 3 months, you take valganciclovir. First 6 months, valganciclovir and cotrimoxazole. So these drugs also can cause low levels. So if you are asking after 6 months, the usual causes are usually mycophenolate, and some
Uh,
of these people
so
do
is
have.
that meaning? Is that meaning high low level of mycophenolate decrease the WBC level?
Correct, yeah, correct, yeah. If you take higher dose of mycophenolate, the WBC will come down, high dose. So some of the patients, so like in our unit, we check mycophenolate drug levels, like tacrolimus, cyclosporin drug levels, we check. So some of the patients take only 250, 250 also. So they have a normal life, their kidneys will work properly. But these people, so many 99% of centers in the world, they don't check this. So these patients, imagine I give them 500 or 750, 500, 500, they will have drug toxicity. They'll repeatedly get admitted with pneumonia, infections. So checking mycophenolate is a good thing, especially in people who are having problems like repeated infections, or people with very low WBC counts, very low hemoglobin. It's good to check mycophenolate drug levels, and that is the number one cause after the 6 months period. And another rare cause can be is because of undiagnosed liver disease. Some because hepatitis B virus infection is higher in Bangladesh than in India, and some of them have C virus which are not diagnosed, and some of them have liver disease even before transplant. So liver disease also is one cause for low counts, but that's not a very common cause, but that also can come. So usually it's nutritional problem, drug problem, and rarely any other disease like liver disease.
Sir, am I audible?
Yeah, now yes.
Okay. So this question is from Riaz Khan. Sir, how a patient can longer his duration to damage kidney?
Can you repeat? I didn't get it.
So these questions.
No, can you ask the question again? I didn't understand.
Uh, uh, Sir, how a patient can longer his duration to damage kidney?
So how to keep the kidney working long time?
Long time is
Long time, yeah. So that is number one is like you need to find out um, before transplant the doctor has to do a good job. So that is before transplant, and in the first 3 6 months to 1 year the doctor has to do a good job. So that is not in your control, patient's control. But after 6 months, so what you should do is you have to take the medicine strictly on time, and the most important medicine is tacrolimus and cyclosporin. So tacrolimus is affected by the food intake. Cyclosporin also, but to a lesser extent. But tacrolimus you have to take strictly with 30 minutes minimum fasting. So if you do that, advantage what you get is your tacrolimus drug level whenever you do, no, it will be constant. Otherwise, one time it will be 6, another time it will be 10, other time it will be 4, other time it will be 3, and the doctor will be confused, you will be confused, the doctor will change, and again some more confusion will come. So keep the time strict. And see, like for example, I'll tell patients, imagine you fix it at 8 o'clock in the morning and 8 in the night. Keep the 12-hour interval and always take it at 8. And your dinner and breakfast will be at 8:30. So imagine some days you can have it 9 o'clock. You can have it 8:45, but don't change your time of your drug. So because tacrolimus is a drug that will save your kidney and save your life, and you should always take it properly. That is number one. Number two is always keep the tacrolimus level between 5 and 7 lifelong. And I have noticed like many time patients, even mother giving kidney, father giving good match, if their drug levels are kept constant and more than 5 for more than 15 years, they do good. But after 15 years, imagine they stop taking medicine, the drug level comes to, they say, 2 3 50. There's a more than 50% chance that the kidney will reject even after like 15 20 years. I've seen patients after 25 years, like after some fever, viral fever and all, especially if their drug levels are very low, less than 4, they can reject. So number one is take it on time, medicines on time. Number two is always do a TAC level at least once in 6 months and keep it between 5 and 7. And if you do this, this kidney can work like 30 years plus. And of course you need to take the other medications also, but this is the most important. This is the most important medicine you are supposed to take. And periodic checkup with the doctor is also a must. Um, and especially many of the patients have diabetes, and because you're doing only transplant for the kidney, you're not changing your diabetes. And diabetes, you have to keep your HbA1c less than 7 if you're a young person, and if you're like more than 60 years old, then at least less than 7, sorry, less than 7.5 you need to keep at older age. But younger age you should try to keep less than 7 and keep your weight under control. And so if you do this, generally you should be able to live long, and don't skip any medicines. But many times in Bangladesh, I've noticed is many of these people tend to have antibody mediated rejection much more often due to many reasons. So when you're planning a transplant, you have to plan it properly so that you don't do transplant with people with kidneys which are your body is incompatible or not matching strictly. So that one, patients are not knowing, doctors also not following good labs, because the doctors, they get guidance from the lab reports. The reports are not very accurate, then the doctor makes wrong decisions, wrong judgment. They give wrong donors who are not matching properly, and then the kidneys keeps on getting rejected in the first year itself. So that is the major reason. So that is doctor's job, but your job is to take the medicines on time. Keep your diabetes, blood pressure under control. That's it.
Sir, this is a very vital question. Let me translate it into Bengali. আমাদের প্রশ্নটা ছিল এমন যে একটা ট্রান্সপ্লান্ট করার পরে কিভাবে লং টাইম সার্ভাইভ করা যায়, অর্থাৎ ট্রান্সপ্লান্ট কিডনি কিভাবেই দীর্ঘদিন ভালো রাখা যায়, এটা নিয়ে তারা বেশ কয়েকটা ইনফরমেশন দিয়েছে। তার মধ্যে প্রধান ইনফরমেশন হচ্ছে যে ট্যাক্রোলিমাস ডোজ, ট্যাক্রোলিমাস যে ডোজে খাচ্ছেন এবং সেই সময় টাইম কনসিস্টেন্সি, যেমন সকাল 8টায় খেলে রাত 8টায় খাবেন এবং এই টাইমটা দীর্ঘদিন ধরে ধরে রাখবেন। তার মানে হচ্ছে ট্যাক্রোলিমাস খাওয়ার সময় পরিবর্তন করবেন না, যে সময় খাচ্ছেন রেগুলার সেই সময় খাবেন। কোনোভাবে আজকে 8টা কালকে 10টা এমন করা যাবে না। মানে মেইন কথা হচ্ছে তারা বলছে ট্যাক্রোলিমাস ইজ আ ভেরি ভাইটাল মেডিসিন। তো ট্যাক্রোলিমাসের ডোজ ডক্টর যেটাই বলো না কেন, খাওয়ার সময়টা কোনোভাবেই চেঞ্জ করা যাবে না, টাইম টু টাইম খেতে হবে। এবং দ্বিতীয় কথা বলছেন যে ট্যাক্রোলিমাস লেভেল যে টেস্ট করবেন সেটা বেস্ট ল্যাবে টেস্ট করতে হবে, কোনো উল্টাপাল্টা ল্যাবে টেস্ট করতে হবে না এবং খুব রিলায়েবল ল্যাবে টেস্ট করতে হবে। এবং ট্যাক্রোলিমাস ল্যাবের কারণে দেখা যাচ্ছে ডক্টরও কনফিউজ হয়ে যায়, একসময় এক ল্যাবে আরেকটা রিপোর্ট চলে আসে। এবং দ্বিতীয় কথা বলছে ডায়াবেটিস কন্ট্রোল, ডায়াবেটিস অবশ্যই কন্ট্রোলে রাখতে বলছেন এবং ওয়েট কন্ট্রোলে রাখতে বলছেন এবং বেস্ট ল্যাবে টেস্ট করতে বলছেন। তো মেইন কথা হচ্ছে আমাদের যে তিনটা মেডিসিন ট্যাক্রোলিমাস, মাইক্রোফেনোলেট এবং প্রেডনিসোলোন, এইটার যে সময় খেতে বলা হয়েছে, যে ডোজে খেতে বলা হয়েছে, এই ডোজটা সবসময় কনস্ট্যান্ট রাখবেন, ডায়াবেটিস কন্ট্রোলে রাখবেন, ওয়েট কন্ট্রোলে রাখবেন এবং বেস্ট ল্যাবে টেস্ট করবেন। দিস ওয়াজ দ্য ইনফরমেশন ফ্রম স্যার। Sir, did you get me
Yeah,
or
I
not?
got it. Yeah. So you said
Okay.
perfectly correct. Yeah.
Okay. This is another question from Joy. And Assalamu alaikum, sir. His wife is your patient. The problem is the different part of his body, blood clot and got black color, and it's a long time consistent problem. And how could she get removed from this?
So I don't know what Joy's wife is having, because if you have black spots in the body, it can be because of we call it inverted papillodoma, or it can be because of the uremic toxin. So in that case, we need to treat it differently. They give them medications, and sometimes it can be blood that is coming and under the skin because of minor trauma. And minor trauma, the blood can get accumulated under the skin, and that can also cause problems. So that can change color from purple to black and green and greenish yellow over a period of time. So that can be that, or because of toxin. So, and rarely it can be disease related skin rashes. So we need to see the patient, or at least see the picture, then we'll know what it is. But by what Joy has described, difficult to say more than this.
জয় ভাই, আপনার ছবিগুলো স্যারকে পাঠাবেন। স্যার যেহেতু তিনটা আমাদের মাধ্যমে মিডিয়া দেখাইছে, যে টাকা দিয়ে টাকা না দিয়ে, এবং হসপিটাল ওয়েবসাইট থেকে আমরা পরে গ্রুপে পোস্ট করবো যে কিভাবে স্যারকে রিচ করা যায়। তো স্যারকে রিচ করতে গেলে আপনি ওই ছবি সহ তাকে ডিটেলস ছবি পাঠাবেন এবং এরপরে কথা বলবেন। Uh, I will take the next question from one of us, Atia Purna, and her question is, and she got her kidney transplant in 2019. In 2023, his creatinine got increased, and he got she did a biopsy in 2014, and the report was FSGS, and his creatinine is getting high and high. She wants to get a second transplant. So if he get another transplant, will FSGS will come or not? And
So
what should be
first
the
question
precaution
is
for
like,
his transplant?
yeah, so first is we need to be very sure that it is FSGS, because in many places, especially in centers where the experience of the doctors who's seeing the biopsy is not very high, they can give wrong diagnosis. So FSGS is one of the commonly misdiagnosed disease. So first and foremost is we have to see whether it's really FSGS. Generally, FSGS which comes and damages the kidney usually comes in the first year. Like you got the transplant in 2019, so usually the disease comes back in by before 2021. So in your case, you after 5 years the FSGS has come. It can come after 4 or 5 years, but then like you, first of all you have to see whether the diagnosis is correct. Number one. Number two is like regarding whether it will come in the second transplant. Of course, it can come, but still, you will doing a second transplant is always better. So here in the second transplant, what we need to do is, instead of checking only when problem comes, you have to check at least weekly in the first month, and then first few months, and second later on monthly for first 6 months, and after that at least once in 3 months, lifelong. Whenever you're checking creatinine, that time you have to check for urine protein. And if FSGS is detected early and it can be treated and cured also, we give proper treatment, 7 out of 70%, that is 7 out of 10 times, it will be completely cured. Completely, FSGS can be completely cured if you diagnose early and treat. In the rest of the 30% of the time, these patients may not get completely cured, but they'll get partly cured. So meaning 90% of the time, the kidney can be protected and saved. In 70%, 100% can be reversed. In the rest of 30%, 50%, that is around 15%, 20% can get partly reversed. Even partly, if FSGS is cured, the kidneys can easily work for 10 years and above. If it's completely cured, then of course it can work for a very long time. So doing second transplant is a good option, and but you have to check for proteinuria more frequently. The reason the doctors probably were not able to save the patient from FSGS is because it was diagnosed very late. By the time the kidney is damaged too much, so when the kidney is damaged too much, then
Yes,
nothing
sir.
works.
Sir, another problem of I'm talking about Purna, she had gone with some cross match with different donors, and most of them came positive.
Oh, okay.
And did she need treatment before going with a cross test?
So in that case, no, like because second transplant, this is a usual problem. It can have problems. So there are 2 3 options available. One is like you can check with multiple donors and find out one which is matching. And if you don't get a match, then there are some injections which can reduce the titers to very low levels. In fact, in I have done this to two of the Bangladesh patients. One of them had 10,000 um, that MFI, and one had like 3,000. Both of them are doing well, and they've gone back to Bangladesh also. One of them have finished 8 9 months now. The other one has finished 4 months. So for them, we reversed the cross match, reversed the problem, and we did it because they had no other options. So there are treatment to reverse the matching problem also, but the best is to find a person who's got best match. In fact, there is one patient who's trying to come because we checked against so many donors, maybe like 6 7 8 donors, and finally we identified one donor. Multiple times it was checked, and there is matching with the donor. And then again we will verify in India, then if required, give medicines to reduce antibodies to very low levels, and then do. So doing plasmapheresis, not a good option if your plasmapheresis alone is given, because if you do plasmapheresis, the disease can come back a few weeks or few months after transplant again. the kidney will not work very long time. So we have to identify that one person where there is a good match, there is no antibody. And if it is not possible, then you have to do transplant with somebody whom the antibody titers are very low. And not all antibodies are equally bad. Some are a little bad, some are too much bad. So if it's too much bad, you
Then
should
she
not
need
do.
to go with DSA.
So DSA, the most of the labs, I'm very sorry to say, most of the labs in India and most of the labs in Bangladesh, they don't do good quality control. So because of that, what happens is you get false positive, you get false negative, and unfortunately, if the doctor, nephrologist, and the transplant team, the transplant surgeon, if they are not well oriented with all this test, they'll make wrong decisions because the transplant immunology tests, they are like very sensitive and they can easily, if it is not done properly, you can get wrong reports. And you can imagine if you do have wrong reports, how can you treat the patient correct? So first and foremost, you need to have a very good lab. And if that lab is not available in Bangladesh or any other city in India also, they need to find out that one lab which is reliable. And the doctor also should be able to know which report is correct, which report is wrong. So we do CDC cross match, the regular cross match, we do flow cross match. And these has to be negative, number one. And after this, we do virtual cross match. So one mistake a lot of doctors in India are now quickly learning and not doing, and they do something called DSA cross match. DSA cross match is a wrong test. It's called Luminex cross match or it's called DSA cross match. So only in Bangladesh and India this test is even available. In developed countries, DSA cross match is not at all available as a test. Not at all available as a test. What it's available is it's called a virtual cross match. That is different. Virtual cross match, they do SAB or antibody profiling, class 1, class 2 antibody profiling, and then they do HLA. And then they look at virtual meaning not real, no, right? They do matching like what we do in schools. We'll see whether there is any antibodies against the um, donor, like that, which that's called virtual cross match. That is a valid test. But DSA cross match is not a valid test and it is not available in developed countries. It is only available in India and that kit, I think some labs in Bangladesh are also using, and it can cause confusion because sometimes there will be a good match, but that test will say no match, and then like people will make wrong decisions. And opposite also, when there is no match, the test will say good match, and likewise
Sir,
they can
one
make wrong
question.
decisions.
If DSA is invalid, then what about PRA?
No, PRA is a very good test. So PRA, it's a very robust test. So if PRA is negative, you can be pretty sure that severe rejection will not come 95, 99% of the time. 95, more than 95% of the time, severe rejection will not come if PRA is negative. So if PRA is positive, then we need to find out is there any significant mismatches. So what I do for my patients is I will do a PRA, and 8 out of 10 patients, the PRA will be negative. If the PRA is negative, you can happily do the transplant. Of course, you have to do few other tests, but the risk of complications and especially severe rejection is very, very low. Very low meaning like if I do 100 patients, only 5 will have some kind of antibody rejection. 95 will not have. I can be pretty sure that they will do very well. So PRA is a very good test, and all of you should do a PRA. And if PRA is positive, then you have to find out whether there is antibodies present against the donor antigen. And if it's present, then you cannot do it, or you have to do some extra treatment to avoid problems.
Thank you, sir. Let's have the next question from Tanjinul Islam. Sir, I have suffering from tinea versicolor for 6 months. It's around my neck, hands, and face also. What is the treatment?
So it's easy to treat. Tinea versicolor is one of the very easy things. You have to take ketoconazole shampoo or soap. So if you do that, then usually it goes away, and you have to take for 2 weeks. And sometime it can come again. Then you have to repeat the same thing again. So that is tinea versicolor. And if it's still persistent, then I think some topical ointments has to be taken, and that you have to ask the dermatologist. But this it works 90 to 95% of the time. Ketoconazole shampoo or soap is enough.
Okay, sir. And this question is from many of us, and this question is uh, uh, after long time of transplant, they have abscess in underarm or different part of body and high allergy issue.
So that is because of the humidity of Bangladesh. No? The Bangladesh is a humid country, and also a bit hot country also. So in that case, like tend to have more tinea ringworms are more often seen. So I think so. There are these are the options. One is like you can put clotrimazole powders or cream, and then if it is like widespread, and you have to take terbinafine for a month, and if it's not working, then you can take twice weekly fluconazole along with terbinafine. So these are the options which are very safe. But other options like very resistant cases like micazole and all those things you can take, but in those cases you have to monitor the drug levels and then take. So keeping these areas dry is the key. And if it is coming, you have to use clotrimazole powders and keep it dry. So that's the way forward. And if somebody is having diabetes, the diabetes has to be well controlled. But this is a very dermal skin problem. It doesn't really mean that your immunity is very low. It can come when your steroid dose is high, or your Cellcept or mycophenolate dose is very high. So these two drugs can cause these infections more. So the uncontrolled diabetes, very high steroids, and very high Cellcept in the body can cause also. In that case, the doctor has to make a decision to reduce these drugs.
We have many more questions. It's not possible to take all of the questions, sir. I will take the last question from one of us, and he is taking silnidip, cardizem, bisoprolol, and prazopris, and all are blocker. He is just tense. He is just uh, tensed about his infertility problem. Will it cause any infertility?
Can you tell me the list of
We are
drugs or
talking,
list of
sir,
drugs?
let me see. Bisoprolol, silnidip, uh, prazopris, clonidine, clonidine, and this, sir, no,
And the last one?
uh, bisoprolol, prazopris, silnidip, arcamin,
Okay. So the most
clonidine
common cause,
hydrochloride.
and last one?
Uh,
Clonidine. Okay. So
Clonidine,
clonidine,
yes.
I'm not sure whether it can cause impotence, but it can make you feel weak, and then like you may not want to do anything. So the best medicine for impotence is exercise. Exercise. That is because the moment you do exercise, your fat level comes down. The moment fat level comes down, your testosterone level goes up. And even the body, whatever testosterone is produced, it is continues to stay as testosterone, and they don't get damaged or metabolized to inactive metabolites. So the best form for virality is exercise and reduce your fat, total body fat. So that's what, if you see like the the so that is why women tend to like people who are very thin, like muscular and thin, because they tend to have high testosterone levels in the body. So women know, looking at the face, that okay, this man has more testosterone. So that is one. And secondly, doing exercise and losing weight, no, your blood pressure also comes down. You don't need so many medications. And third thing, no, like you need to take all the medicine such a way that BP is really, really controlled. Only when they're really, really controlled, so many drugs can be reduced. Like in my experience, nobody takes 5 medicines for more than 3 or 4 months. Because if they really take all the medicines properly and the doctor also gives enough medicine to reduce it, usually after 1.5 months to 6 months max, the blood pressure keeps reducing, and after that you'll be only taking 1 or 2 medicines. And also leg swelling and our body swelling should not be there. With during treatment. If you reduce all the swelling, keep all the blood pressure well controlled, the blood pressure usually disappears to one drug, two drug. And the best way for potency is reduce weight, reduce fat, not weight,
Okay,
reduce
sir.
fat,
I-
do exercise.
If any of if anyone stop blocker and convert with low certain potassium or any other medicine, that medicine will increase our creatinine. So
Yeah,
is
so what
uh,
it can sometimes increase. So what you have to do is you have to start very slow. You have to start like 12.5 milligram losartan. So usually that's not very mild drug, but that can be a magic drug in reducing blood pressure. It can blood pressure can reduce very significantly, and the creatinine may not really increase. And one thing we all should know is taking losartan, telmisartan makes you live long, because you will not die of stroke, MI, or even kidney failure. It
sir,
does really protect.
what should be the dose, sir? Then 25 milligram BD.
No, the highest possible dose has the best benefit. But then, like, even if the creatinine increases from 1.1 to 1.2, 1.3, all of us get worried, right? So what I would suggest, you take a very small dose. You can take 25 milligram losartan, or even half of that, 12.5 milligram. Just see how the body is reacting. And then, so like if your body is reacting good, everything is okay, then you can continue or increase the dose. That way, like if you try for 10 patients, no, 5 of them will be happily taking. Another 5, that they'll be uncomfortable. The creatinine will increase a little bit here and there, and you will want to stop it. But then it's a very good drug, and that will improve your chance of surviving long time. So some of the question, no, I've translated. So they put in Bangla. So they said, sir, a Prograf is not available. Can I take different company drug? They said. So of course you can take, not an issue. But only thing is, anytime you change, only two questions you have to ask yourself. One, what is the brand? Is it a good company or not? If the company is good, standard, and the expiry date is it's well within expiry date, you can take it. But anytime you change, you should always do a drug level. And as I initially said, keep the tag between 5 and 7. And if it is a mother donor and matching is good, maybe you can keep it at 4.54, but nothing below 4. So anything less than 4, and this also under the presumption that the lab that is doing the level test is doing it very accurately. So that is that. And Laboni Hassan has asked, like, my mother had 1+, then trace now. My mother is taking Abitis. Only current problem is creatinine is 2, the hemoglobin is a bit low, and mouth ulcers are present. But I think first is you have to do a biopsy to see what is the cause for protein. So then only you should even try to give any medicine. So just blindly giving Abitus is okay. And as I said, for mouth ulcers, you need to give either injection cyanocobalamin or B complex vitamins like riboflavin, and then try and see if any of this works.
Okay, sir. Sir, please answer this question from Ahad Bhai. Is it
Pardon?
visible?
No.
Okay. Uh, uh, Let me just translate. My transplant has been running for 5 years. White spot appeared in the back part of the body. What should I do? White spot.
What spots up in the back of the body?
mm, some white spot appeared on the back of his body after five
Again,
years
very
of
difficult.
transplant.
Yeah, so very difficult to see, man, what are these white spots are like. Generally, like people who take steroids, they can have some spots in the back. So these are all nothing but oil glands, body's oil glands, which are like having some blockages, and that is causing some minor infections. And that is one. And other white spots can be tinea versicolor, which can be easily be treated with ketoconazole shampoo or soap. So these are the two most common causes of these white spots, and these are all very benign ones, meaning that they do not cause major problems. They are not something to be really worried about. So this
Sir,
one is
let me just
an
explain.
important question they have asked. That is, I have large
Okay.
boils that comes and goes. I have transplanted 10 years ago. So large boils generally come when if the diabetes is uncontrolled, if the hygiene is poor, or sometimes these bacteria love you so much they just don't want to go away. They keep coming and causing infections in the body. And third is when there are too much of immunosuppression. So the medications what you're taking is reducing the immunity too much. So these cases, like you have to, if everything is doing good, you're doing well, then you may have to even consider reducing sorry, the dose of Celsep too much. You need to reduce, and that's a decision the doctor has to make, especially if it's coming repeatedly. But generally, it means immunity is low. One question the person has asked is how many years a CKD patient can take steroids. So if you're going to take 5 milligram or less of steroid dose, you can take for like 50 years and still may not have any steroid side effects. So anything 5 milligram or lesser for long term does not cause significant complications. But if you take anything more than, I would say, 10, you will have some problems. So there is no cutoff. If this medicine is going to make you live like say 50 years, forget the cataract and other minor problems you may develop. But many of the Bangladesh patients take very high dose of steroids. And that is the reason they develop pneumonia and many dangerous complications. So steroid is the
Okay,
most
sir.
toxic medicine post-transplant, and you have to be very, very careful in taking that medicine.
Okay, sir.
So this guy has put in very
Um,
interesting Tanchil Islam. 3 years
Tanzil
post
Islam.
transplant, my blood pressure is 190, and after taking Siltip 10 in the morning, it goes to 170. And so forget, then that means you should not take any BP medicine, boy. So don't take any medicine, and cut down on your salt, and then your blood pressure should be okay. If you're worried about your diastolic pressure, which is like 90, so in these cases, no, you cannot treat it like 110 by 90. You have to only pray to God, because at this level, no, you cannot try to. If you try to try to treat the 90, your 110 will become also 90. So you don't have to find any solution. So here, nothing is going to happen to you. So you're going to live long happily. So in these cases, if you want to reduce it, try non-medication therapies. Like try to do 15 minutes more walking. Try to reduce your salt in the food you are taking. And if your potassium is really normal, you can take something called low sodium salts. I don't know. I have not seen that in Bangladesh. There are so low sodium substitutes where 10% of your normal salt is
Most
supplemented
probably
with potassium. Low
pink
sodium.
salt or low salt.
Yeah, pink salt contains
Pink salt
5%,
Himala.
around 5% of potassium. But in India, we have low sodium salts which have 15% and sometimes even 30% potassium chloride. They are dangerous if the
Okay.
potassium is high, but if they are very good drugs, very good salt when your potassium is absolutely normal. So those kind of things you can try. Like that will be going to be solving your BP problem rather than trying to take some medicines.
Okay, sir. Sir, let me translate some important issues in Bangla. তো আমাদের অনেক প্রশ্ন ছিল ডার্মাটাইটিস ইস্যুতে, কারো অ্যাবসেস হচ্ছে, মানে হচ্ছে ফোড়ার মতো হয়ে যাচ্ছে, কারো শরীরে বিভিন্ন জায়গায় সাদা দাগ লাল দাগ হয়ে যাচ্ছে, কারো অ্যালার্জি হচ্ছে। তো নর্মালি স্যার যেটা বলছে কিটোকোনাজল শ্যাম্পু। তো আমাদের দেশে সম্ভবত নিজোডার নামে একটা শ্যাম্পু পাওয়া যায়, আপনারা গোসলের সময় ওই শ্যাম্পুটা ইউজ করতে পারেন, ওটা দিয়ে ইউজ করতে পারেন। আর যাদের দাদের মতো আছে তারা একটু লং টাইম ইউজ করে গোসল করে ফেলবেন। স্যার যেটা বললো মূলত এটা এনভায়রনমেন্টাল ইস্যু, আমাদের হিউমিডিটি বা হচ্ছে আর্দ্রতাটা অনেক বেশি থাকে, তো হিউমিডিটির কারণেই মূলত এই ধরনের হয়। তো অনেক গরম হয়, কারোর সময় শুকনো থাকা ট্রাই করতে বলছে, যে এক ধরনের হাইজিন মেনটেন করতে বলছে, আন্ডার গার্মেন্টস বা অন্যান্য যেসব ঢিলে ঢালা পোশাক পরতে হবে। এবং হচ্ছে বললো যে এই ধরনের ইস্যুটা বারবার হচ্ছে, আপনারা কিটোকোনাজল শ্যাম্পু, কিটোকোনাজল 2% বাজারে ডিজোডার নামে একটা শ্যাম্পু পাওয়া যায়, শ্যাম্পুটা ইউজ করতে পারেন। একটা ব্র্যান্ডের নাম বললাম, বাজারে বিভিন্ন ভাবে নামে পাওয়া যায়, ওটা ইউজ করতে পারেন। আহ বিকজ এটা অনেক কোশ্চেনের আনসার, তো তাই বাংলায় বলে দেবো। এরপরে কারণ কোশ্চেন কোনো বুঝতে সমস্যা হলে আমাকে গ্রুপে টেক্সট করলে বাংলা কনভার্ট করে দেওয়া হবে। স্যার মোস্ট প্রবাবলি we haven't any question till now, we answered all the questions.
Yeah, so I can also leave my email ID, man. So in case somebody wants to write to me regarding any of their problems, um, they can just write to me. ilangovanb@gmail. So I will try to answer.
The trend of high prednisone is from Bangladesh and Kolkata, as far as I think.
Which one?
The trending of getting high steroid prednisolone is is very regular in Bangladesh and Kolkata, West Bengal.
Okay, West Bengal they give high steroid, is it?
In Bangladesh also.
Yeah, that I know that. Yeah, so even in Calcutta also they give high steroids. So that is not good in the long term because the steroid that is the one that causes a lot of problems.
Yes. Uh, okay, so you just send me the mail. Oh, okay. Uh, Thank you, sir, for giving us the time. And the most important cause of inviting you, how we will get you, and we get enough answer and how to receive. Sir, one more request, sir. Whenever you come to Bangladesh, please inform us. At least inform me, and then I can spread it to everyone. And
Sure.
sir, we will all request you to come to Bangladesh at least 1 or 2 times in a year, and we all are waiting for you. And
Sure. Sure.
lastly,
I'll plan it. Yeah.
I will thank you, thank you, and will invite you again and again. And sir, and the core of my heart and core of our heart, we think we just say we all love you very much.
I
All the passion
I
parts,
too
we
love
love
you
you
all.
very much.
Yeah,
Uh,
I too love all of you.
sir, uh, sir, we'll leave now. Sir, before leaving, we can take a question from Mashur Rahesh, one of your passion. Uh, Sir, my first transplant done is 2021, but in 2024 has been damaged antibody-mediated rejection. I want to do a second transplant. What can I do? What will I sense for that? And he's trying for second transplant for the very long time, and most probably he is your passion.
Yeah. So basically, for him, like his case was very. I hope I want to share his story so that like people understand the seriousness of this test. So so what happened was like I'm not going to name the hospital. So he did the immunology test 4 times, and I mean, 3 times in one place. In two places they said there is a good match, and only in one place they said the matching is not good. So he got confused and he came to me to my hospital. So I looked at all the reports and I was also confused like him. So then, because I knew some labs which are very good, I spoke to them. I said, "This is what is the problem. So you need to give me clear answers as to why this is happening." So they did, and you'll be surprised to the answer I'm going to say. So there's something called prozone phenomenon. Prozone phenomenon meaning when the antibody titers or the levels are very high, the reports can come as falsely normal or negative or a good match. And that these two labs, one of them is very popular lab in Bangladesh. Most of you are sending sample to that lab, and that is an Indian lab you're sending, and they also missed it. So that means they are not following proper protocols, and that is the reason this is happening. So I spoke to the lab. I told them, "See, this is what you are doing. Be careful next time." And I've stopped sending samples to that lab. And I because they are not changing, they are not accepting their mistake. And then I stopped sending any more samples. And I have my local lab here. We still send it outside, but that lab is very good lab. So these days we trust that lab. So one is that you have to be very careful with these tests, because if you do a second transplant, that will also get rejected if your reports are not good. So during not able to find a donor, sometimes no, not doing transplant is good. You do transplant and you spend money, you spend, and sometimes you even lose life. It's not good. So the best way of doing this, you have to find a donor which matches, or you have to do transplant in centers which can do something called desensitization, remove the antibodies, and make sure the kidneys work very long time. So most of the transplant centers, even in India, cannot do high risk transplants. So so if you have to, if you're going to any hospital in the world, so you have to ask clearly the doctor, how many patients you have done patients like me, and what are the outcomes long term, 5 years, 10 years, 20 years, what is the outcome? Most of the doctors generally will be honest and they will tell you the real outcomes. So to honestly ask, okay, doctor, now then you are accepting to do, but what will happen? Tell me, like if 10 people like me do, what will happen to
But
my?
his first donor was his father, sir.
Yeah, it doesn't matter. So like, what happens? No, like God has created body so much. There are times where completely zero HLA match can work 40 years, and there can be like 100% match with zero mismatch with their mother father. The kidney will not work even 1 week. So there are some things like which is beyond. I cannot explain here in this meeting, but it can happen, and there are reasons why it happens. In fact, I recently did a year, almost 9 months, 10 months back. This patient came for third transplant. First two transplant did not work even 1 year. It failed in 1 year, and he came to me for third. And by God's grace, we did biopsy 3 times. There is no rejection because we knew before the transplant what is his problem. We corrected the problem, then only we did. So that is what we did, and so you have to be very careful, and you need to find the right donor. And if you don't find the right donor, find the donor where the mismatch or the antibodies titers are very low, so that that kidney at least can work 10 years and above. Otherwise, better not to do.
Thank you,
So
sir.
the
And
Sarkar Shuvo is asking, like he's taking 7.5 mg Corton, he's having a lot of skin problem. So if what I would suggest is, first of all, no, you need to discuss with your primary doctor because your doctor knows about you best. So if you never had any kind of rejection, even the mildest form of rejection ever, in the then maybe you can reduce from 7.5 to 5. Nothing would happen.
he
Nothing would
has some
happen. But
issues
again,
of increased creatinine, sir.
pardon? Yeah, if there is an increased
As far as I
creatinine,
know, he has issues. Most probably
yeah.
he may have
So in that
rejection.
case, no, better not to do it because if you try to tinker with 7.5, no, the rejection can worsen. So continue the same. So if you have skin problem, no, you can take a short course of antibiotics like amoxicillin, clavulanic acid, or azithromycin. So usually this skin problem generally disappears. 7.5 usually it's not a very high dose. It's not like 10 mg or like more than 10. Generally it's manageable, but if the creatinine is abnormal, don't try to reduce it. It's dangerous to reduce.
Uh, we have answered all the questions, sir.
Yeah, almost
Thanks
all.
a lot
Some,
again, and again. Yes, sir. Thanks a lot again. Hope we'll meet you very soon. And all of us will have the easy access to reach you.
thank you,
Uh,
Rafi. Thank you, Rafi,
thank
for
you.
providing the opportunity. I'm not able to see all of you people except Rafi. I would have been happy to see some more faces. But thank you, Rafi, one
Thank you.
more time. God bless you all,
Thank you,
and
sir. Thank
God
you
bless you.
again. Thanks from our team. Thanks from our transplant patients. And thanks
Thank
from
you.
Bangladesh. Thank you, sir.
Thank you. Thank you. God bless you all.
Mm.